Hello and welcome to MK's medical review series. We shall continue with our ECG lecture videos that we are carrying on this current week. My name is Dr. Moses Kazevu. Now these are a series of lecture videos that are getting you from being confused about what you're looking at concerning the ECG to becoming an expert at the ECG. And in this lecture video, we shall look at the introduction to conduction problems. We'll look at heart block, we'll look at bundle branch blocks, and then we'll conclude conduction problems in part 5 of these lecture videos. In the past 2 or so topics, we looked at the introduction of the ECG. If you haven't watched that, I'll leave a card right here on your screen. And I'll also leave a card for the interpretation of the ECG, both part 2 and part 3, also showing here on the right of your screen. So please click here to watch those videos, and so that you could get the gist of what is going on in these subsequent lecture videos. So in this lecture video, we'll look at pretty much conduction problems. What could go wrong in the conduction of the heart? Remember that for normal sinus rhythm, the impulse has to be generated in the sinoatrial node, or the SA node. And then eventually this impulse is going to spread towards the atrial muscle and then reach the AV node. So when it reaches the AV node, this impulse is going to be carried down the bundle of His, and then eventually the bundle of His is going to divide into a right and a left bundle branch. Remember that the right bundle branch supplies the right ventricle, the left bundle branch supplies the left ventricle, and then the left bundle branch is divided into 2 fascicles. You have an anterior fascicle as well as a posterior fascicle. Now, when you talk about conduction problems or conduction abnormalities, this wave can either be delayed or it could be blocked at any point along this system. So for us to actually appreciate these conduction abnormalities or conduction problems, it's very easy that you keep this conduction system diagram in your mind. So remember that this impulse is starting off at the sinoatrial node, and then eventually is going to depolarize over the atria, and then this impulse is going to reach the AV node. There's a delay between the impulse starting off from the SA node and reaching the AV node, and this delay is manifested on the electrocardiograph as a PR interval. So the PR interval normally should be 3 to 5 squares. That's about 0.12 seconds to 0.20 seconds, so 120 milliseconds to 200 milliseconds. Then eventually this impulse is conducted down the bundle of His, and then the right and the left bundle branches, and then the left bundle branch divides into a posterior fascicle as well as an anterior fascicle. So keep the wiring of this diagram in mind, because you could have blockage of the impulse being transmitted from the SA node to the AV node. You could have blockage of the impulse being transmitted from the AV node to the bundle of His. You could have each one of these bundle branches being blocked. So remember that for us to actually determine the rhythm of the heart, it's best that we look at the P waves, which show or the lead which shows the P waves that are very clear. So most of the times it's lead 2 or lead V1, because the P waves are very clear there. So please, when you're assessing the rhythm, look at the rhythm strip for lead 2 or lead V1. But sometimes this is not always the case, but in most cases we usually focus on lead 2. That's why you have been seeing that most of the examples I have been giving you are based on lead 2. So the different conduction problems that we'll talk about, you could have heart block. There are 3 degrees of heart block: the 1st degree, 2nd degree, and 3rd degree, which we shall talk about in this lecture video. Then of course there is a bundle branch block, which is left bundle branch block, right bundle branch block. Then remember that the left bundle branch divides into 2. You could have an anterior fascicular block, you could have a posterior fascicular block, which we shall also talk about subsequently. So we'll start by looking at conduction problems that are going to be affecting the transmission of the impulse to the AV node. So remember that the time that it takes this depolarization to spread from the SA node to the ventricular muscle is known as the PR interval. Like I said, the normal PR interval is 3 to 5 squares, the small squares. So that's about 0.12 seconds to 0.20 seconds. Now, if there's an interference with this conduction from the SA node to the AV node, this will kind of like prolong this time. So you refer to that as heart block. So you have 3 degrees of heart block: first degree, second degree, and third degree. So in first degree heart block, you have a depolarizing wave that is obviously starting off in the SA node, but is conducted down the ventricles, but at a much slower rate. So there's a delay somewhere along this pathway from the SA node to the AV node and down the ventricles. So the only thing that we'll see on the ECG, sorry, I have X-rays on mine. The only thing that we'll see on the ECG is pretty much a prolonged PR interval. So on the first degree heart block, we don't really need to worry about it, because it may sometimes be like a normal variant in some individuals, and sometimes it may actually point you towards certain diseases. I want you to keep coronary artery disease, because most of these conduction abnormalities are due to coronary artery disease, mostly due to either ischemia or fibrosis, or it could be due to acute rheumatic carditis. Remember that in rheumatic fever, the minor criteria is a prolonged PR interval, like we talked about in the previous video. If you haven't watched the video on rheumatic fever, again, I will add the card here, so please click on this card on your screen. Then someone may sometimes be taking some digoxin toxicity due to digoxin. Then you may also get some electrolyte disturbances causing a first degree heart block. Again, the majority of people watching these videos are not yet subscribed to the channel, so please subscribe to the channel, drop a like, drop a comment, share the channel, and just support the channel so that we can keep making videos such as this one. So here's an ECG showing you first degree heart block. Like for example, I've taken the lead 2 as an example. So let me just zoom this in for you so that we could go through this together. So first of all, remember when you're looking at your ECG, you're first going to be looking at the ECG details. We are then going to be looking at the rate, but before we look at the rate, we ask ourselves, is the rhythm regular? So if we look at the waves that are present, so we'll start with this. So you have a P wave here, a QRS complex, and a T wave. A P wave, a QRS complex, and a T wave. A P wave, a QRS complex, and a T wave. A P wave, a QRS complex, and a T wave. And of course, the distance between these two is regular. Okay, so it's almost equal. So if you were to even get a paper, mark this point here, mark this point here, then move your paper along 3 successive waves, you'll find out that this distance is actually equal. Now, I'm really focused, or want us to focus on the PR interval. Remember that the PR interval starts off from the beginning of the P wave to the beginning of the R wave, or the Q wave rather. So if you look at this diagram here, if we count the small squares, so there's 1, 2, 3, 4, 5, 6, 7, about 7 squares. We count here 1, 2, 3, 4, 5, 6, 7, 8 squares. We count this here as 1, 2, 3, 4, 5, 6, 7, 8 squares. We count this as 1, 2, 3, 4, 5, 6, 7 squares. So as you can see, it's almost fixed, either 7 or 8, and that's already longer than the usual PR interval. So the PR interval here is prolonged, and there are no QRS complexes that are missing from this ECG. You have all the waveforms that are present, and the fact that this ECG width of the QRS complex is normal, it means that the problem is not in the ventricles. So the only thing that we note from this ECG is a prolonged PR interval, which is what we see in first degree heart block. And here's another example of a first degree heart block. Notice you have a P wave, a QRS complex, and a T wave. A P wave, a QRS complex, and a T wave. A P wave, a QRS complex, and a T wave. You may see that this T waves may appear a bit taller. A P wave, a QRS complex, and a T wave. Okay, a P wave, a QRS complex, and a T wave. So the PR interval here was calculated to be 360 millimeters per second. Again, if you can't see these diagrams very clearly on your video, I shall leave the link in the bottom of the description of the video so that you could find these PowerPoint presentations on the Dropbox. So how do we manage a first degree heart block? Remember, we treat the patient, not the ECG. So in all the conduction abnormalities that we're talking about, we treat the patient and not the ECG. So if they're asymptomatic, you pretty much don't do anything about it. But if there are symptoms, you do relieve those symptoms. So in first degree heart block, like I told you, it's almost normal in some individuals, but it may point you towards acute myocardial infarction. It may point you towards acute rheumatic fever as two important causes that you need to keep in mind. So there's usually no specific action that is done against the first degree heart block, though you manage the underlying cause. You manage the myocardial infarction, you manage the rheumatic fever. Then the second degree heart block, here you have three types of, or three variations. I know in the prior lectures I told you that there are two types, but there is actually a third type of variation, which we shall look at. So here, some excitation that is going to be starting off in the SA node reaches the AV node and goes to the bundle of His. Some don't. So you have some impulses passing through, some impulses don't. So if this is occurring intermittently, you refer to that as a second degree heart block. So there are three types. There's what is known as the Morbitz type 1, which is also referred to as the Wenck-Back phenomenon. Then there's what is known as the Morbitz type 2. Then there's what is known as an alternate conducted as well as non-conducted atrial beats. So you can call it as a 2-1 type or a 3-1 type. I'll explain what 2-1 is and I'll explain what 3-1 is very shortly. So with the Morbitz type 1 or Wenck-Back phenomenon, what you're going to have that's characteristic of this type of heart block is that there's going to be a progressive increase in the PR interval, and you reach a point where the PR interval increases and all of a sudden you have a P wave but no QRS complex. So you have an increase. Like for example, you may start off with even a normal PR interval. You may start off with, like, let's say 4 squares, then you increase to 7 squares, then 8 squares, then eventually you have a P wave but no QRS complex, and then another P wave. Then the next PR interval usually is short. It's usually shorter than the other PR interval. So you get back to a 3 and the cycle repeats again. So let me show you exactly what I'm talking about. So here I've put some lines on the screen to help you see what I'm talking about. As you can see, the PR interval here is progressively increasing until you reach a point where you have a P wave but no QRS complex. You have another P wave and you see how this PR interval here is much shorter. Then the cycle repeats itself. Then you refer to that as a second degree heart block, Morbitz type 1. Now if you look at the rates of this ECG, that simply depends on the rhythm. The rhythm, of course, here would be irregular, so you would just simply count 30 squares, then multiply the number of QRS complexes by 10. So 1, 2, 3, 4, 5, 6. So about 60 beats per minute, which makes sense because there's a delay in the movement of some of the impulses. So the P waves are normal. The QRS complex is normal in where it's present. The only part where it's abnormal is, of course, this part here where it's absent. Then here's another example of Morbitz type 1 or the Wenck-Back phenomenon. As we can see, there's a progressive increase in the PR interval until you reach a point where you have a P wave but no QRS complex. Then the cycle begins again, and then you have a P wave but no QRS complex. So you have one P wave that's not really conducted to the ventricles. Then in Morbitz type 2, here you have a constant PR interval, but you're going to have some atrial contractions that won't follow ventricular contractions. So you're going to have some P waves that are present, but no QRS complex. But the PR interval is constant. The difference between type 1 and type 2 is that in type 1, the PR interval progressively increases until you lose the QRS complex, then the cycle begins again. In type 2, there's a fixed PR interval, but you still have some P waves that are not followed by a QRS complex. So as you can see here, the PR interval here is constant. It may actually be normal or prolonged. If we look at the PR interval here, it's actually normal. So 1, 2, 3, that's normal. 1, 2, 3, that's normal. But you see what's happening here? You have a P wave, nothing, another P wave. So that's Morbitz type 2 type of heart block. Here's another example of a Morbitz type 2. As you can see, if you look at the PR intervals very closely on this diagram, the PR intervals are constant. So this distance here is the same as this distance here, is the same as this distance here, is the same as this distance here. But you have this area here that is circled in the ink. You have a P wave here, nothing in between, another P wave in a QRS complex. Now the third variant, or the third type of heart block, is where you have an alternating conducted as well as non-conducted atrial beats. So in this case, you have like one conducted atrial beat that is followed by two non-conducted beats. So sometimes this is going to mean that you may have one you may have one P wave and or two P waves and one QRS complex, or you may have three P waves and one QRS complex. So you call that as a 2-to-1 block or 3-to-1 block. And of course the PR interval may vary. So in this case, in a 2-to-1, the PR interval here is normal and it is constant, but you have an area where you have two P waves. As you can see here, there's a P wave. Sometimes these P waves may coincide with the T waves and may actually depict as if there's some peaking of the T waves, but this is just simply because of the P waves that are there. So you have a P wave here, another P wave here, QRS complex, a T wave, a P wave, a QRS complex, a T wave, and another P wave. So this is known as a 2-1 conduction. So like I already told you, the P wave may only show itself as a distortion of the T wave. So here's another example of 2-1 conduction where the T wave may appear like as if it's peaked, but this is only because of the P waves. So as you can see, there is another bump or another notch here if you look very closely. So you have a P wave here, another P wave here, you have a P wave here, another P wave here. So that's a 2-1 conduction. Then how do we manage second-degree heart block? Remember, again, we're treating the patient, not the ECG. So the causes of second-degree heart block are largely the same as compared to those of first-degree heart block. So acute rheumatic fever, but more commonly acute myocardial infarction. So if you have a Wenck-Back phenomenon or type 1 morbids, usually that's benign, so they do not need so much treatment. But if you have a morbids type 2, if you have a 2-1 heart block, this may actually precede a complete heart block. It may precede a third-degree heart block. So those ones with morbids type 1 and morbids type 2, they do not need specific treatment. But those with the 2-1 heart block, you may need to actually add a pacer. So you may perform temporal pacing or a permanent pacemaker inside the heart, especially if the ventricular rate is very slow. Now, last but not least, with the heart blocks, you have a third-degree heart block. This is also known as complete heart block. So here, the atria contracts, but then the atrial impulse is not really transmitted to the ventricles. So remember the other time when I told you that the tissues that are present in the conduction system have a property of automaticity, meaning that if the SA node isn't firing and they'll wait for some time, they'll also generate their own action potential. So when they generate their own action potential, we refer to that as an escape rhythm, or an escape mechanism. We'll talk of escape mechanisms much later, but remember again, the rule of thumb is that if this impulse is being generated from within the ventricles, usually the QRS complex will appear broad. If it's generated above the ventricles, then the QRS complex will most likely be narrow. So remember that it's also not so easy to identify a complete heart block on a 12-lead ECG. You may have to actually look at all the QRS complexes in all the leads. So I'd advise you to look at all the QRS complexes in all the leads. Look at all the PR intervals in all the leads if you want to distinguish a third-degree heart block, because there's going to be a dissociation. You won't see a pattern between the P waves and the QRS complexes. Sometimes the PR interval may vary greatly. So you may see that you have some P waves actually coinciding with some QRS complexes, and the atria will be beating with their own rate, which is much higher. The ventricles will also be beating with their own rate. So with complete heart block, usually it's going to occur in myocardial infarction, especially this happens in a transient state or in the acute type, or sometimes it may be in a chronic state. Usually if it's in the chronic state, you're thinking of fibrosis around the bundle of His. And you may also get a complete heart block, for example, if you block both the right and the left bundle branches. So that could also present to you just like a complete heart block. So here's a diagram of third degree heart block that I was telling you about. So as you can see here, you have a very long PR interval over here. You see what's something happening here with the QRS complex. You have here, and then you have a P wave here. This PR interval is also much shorter than this. You have this PR interval here, which is short. It's like you don't even know what's happening here. You have a T wave here, a P wave here, another P wave here. So it's like the atria are beating on their own, and the rate is usually much faster. The ventricles are also beating on their own, so they're about 40 to 60 beats per minute. And if the escape rhythm is coming from the junction, it's usually less than it's usually 40 to 60. If it's coming from the junction, it's usually less than 40. Then of course, though the P waves are normal, and they may be superimposed sometimes on the QRS complexes, sometimes they may be superimposed on the T waves. So take note of that. Then the QRS complex usually is normal if the ventricles, if the escape rhythm is coming from the junction. So everything that's coming in the ventricles, then it will widen the QRS complex. That's the rule of thumb. So here's another example of a third degree heart block. As we can see here, the rate of the atria is about 90 beats per minute, while the rate of the ventricle is about 36 beats per minute. So as you can see, there's no relationship that we can see clearly on this diagram between the P waves and the QRS complex. And of course, having an abnormal shape of the QRS complex means that the depolarization is coming from the ventricles. Then here is an ECG that is going to show you complete heart block. So if we analyze this ECG, so we have lead 1, lead 2, lead 3, lead AVR, AVL, AVF, lead V1, V2, V3, and I suppose this was V4, V5, and V6, though this diagram was a bit cut. Apologies for that. So if we are interpreting this ECG systematically, remember we're starting off with the patient details, of course, which we do not have. We then come to look at the rate on this. Remember when we are calculating the rate of this ECG, we're simply first going to be asking ourselves, is the rhythm regular? And what thing are we going to look at the rhythm? So if we look at lead 2, do we have a P wave? So we have a P wave here, a QRS complex, and a T wave. Then let's look at this here. You have a QRS complex and a T wave here, a P wave, a QRS complex. Okay, fine, fair enough. The rhythm here is fairly regular, so you can simply count the squares in between these QRS complexes. So I won't spend much time on that because I covered that when we were talking of interpretation of an ECG. Then we look at cardiac axis. So we look at lead 1 and lead AVF. You see the QRS complex in AVF is facing upwards. The QRS complex in lead 1 is facing downwards. So it means that this ECG is showing that there's right axis deviation. And if we look at most of these QRS complexes, if I actually zoom in to the QRS complex, you can see that this QRS complex is more than 1 to 3 small boxes, so it's broad, meaning that this impulse is actually being generated from the ventricles. And then, so this person here had right bundle branch block, though we could not really determine what was causing this, but they also had complete heart block where there was no proper association of the P waves with the QRS complexes. And some P waves you can actually see at different positions. So this is complete heart block. Now, how do we manage third degree heart block or complete heart block? So most of the times, if someone gets a complete heart block, you should suspect that it's more or less fibrosis rather than ischemia. So you should either consider temporal pacemaker or a permanent pacemaker. Thank you for taking your time to listen to this review lecture video. I hope it really helped you understand heart block. In the next lecture video, we shall look at other conduction abnormalities. Until next time, bye-bye.